Welcome back to the Deep Dive. Today we are taking on, well, a really complex subject. It's one that truly separates the informed professional from the genuine expert. The development and the congenital anomalies of the female genital tract.
Exactly. And the source material you've shared is, frankly, dense. It's comprehensive. It really demands that master-level analysis we aim for.
So our mission today is to push past just knowing the definitions. We want to achieve that professional mastery you're talking about.
And it's uniquely challenging, this area. The anatomy is intricate, and the embryological processes, they're incredibly time-sensitive, very interdependent.
So when we talk about anomalies of the Müllerian ducts, what kind of numbers are we looking at?
We're estimating about 1% to 2% prevalence in the general female population.
1 to 2%. Okay, that doesn't sound like a huge number initially.
No, but the thing is, the vast majority of those cases, they go completely undiagnosed. They're silent.
But the ones that do present clinically?
That's where the expertise is critical. They can cause devastating chronic problems. We're talking recurrent abortions, preterm deliveries.
Severe cyclic abdominal pain, right?
Yeah.
Or even those acute obstructive emergencies like hematocolpos.
Exactly. Hematocolpos often means immediate surgical intervention is absolutely needed. It's an emergency.
So the clinical need here, it's really defined by the underlying embryology.
You've hit it exactly. You simply cannot study the genital system in isolation. It's impossible. The genital and urinary systems develop in such close proximity. I mean, they derive from the same early structures.
So an error in one often signals an error in the other.
Almost mandates an investigation of the other, yes. If you diagnose a Müllerian anomaly, your very next thought, your next step, must be to look at the renal tract. Every single time.
Okay, so our deep dive today needs to be systematic. We'll trace the embryology, right, from the primitive structures.
Then we analyze the critical failure modes. Is it aplasia, a failure to develop? Is it a fusion problem? Or a resorption failure?
Got it. And finally, we'll detail the modern clinical classification systems, like E-SHRI-AGE, that professionals really use to communicate effectively about these complex cases.
Exactly. That's the path to mastery.
All right, let's start at the very beginning then, the shared blueprint.
Okay, so starting off, we really have to appreciate the sheer complexity of urogenital differentiation. It's a process influenced by, genetic coding, precise hormonal timing, even potential environmental factors we're still learning about.
And when does this kick off?
By the 8th week of embryonic life, we can already observe the intermediate cell mass. It projects near the midline of the upper caelum, the primitive body cavity.
And this mass is the starting point for both systems.
It's the common origin point, yes. And on its inner side, the genital ridge appears that's the future gonad, ovary, or testes.
And while that's happening, the primitive urinary system is taking shape simultaneously, all from the urogenital plates.
Precisely. The sources lay out 3 sequential phases for this urinary system, which is crucial for understanding the little remnants, the vestigial structures we sometimes find later on.
Right, the 3 nephros system.
Exactly. First, the pronephros, it's essentially non-functional in humans, disappears very early, gone.
Okay.
Second, the mesonephros, often called the Wolffian body. Now, this is the temporary functional kidney for a while. It occupies the bulk of that intermediate cell mass, has primitive tubules, glomeruli.
And remnants of this mesonephros, they stick around in adult females, don't they? We see them clinically.
We do. In the adult female, those remnants persist. The straight tubules become the apophoron, sometimes called the organ of Rosenmiller. You find that in the mesosalpinx near the ovary and tubule.
And the renal tubules.
They become the paraphoron. And the main mesonephric duct itself, the Wolffian duct, persists as Gartner's duct. That's a key structure because it can form cysts later. Gartner's duct cysts.
Okay, pronephros gone, mesonephros temporary but leaves remnants. Which brings us to the third one, the mednephros. This is the permanent kidney, right?
This is the one that forms the tubules of the permanent kidney, yes. But the way it connects to the rest of the system, that's the critical link between the urinary and genital tracts. It's all about the plumbing connection.
How so?
Well, the ureter and the renal pelvis, they don't actually originate from the metanephros tubules themselves. Instead, they form from a little outpouching, a diverticulum, that buds off the lower end of the Wolffian duct.
Ah, so the Wolffian duct is directly involved in forming the ureter and pelvis of the permanent kidney.
Directly involved. This outgrowth, this bud, then induces the metanephros tissue around it to form the actual kidney tubules. It's an inductive relationship.
Okay, I see the link now.
Right. But here's where the developmental mechanics get tricky and where things can go wrong leading to pathology later. There's subsequent rapid growth of the surrounding mesoblastic tissues.
And this growth pushes things around.
It causes the ureter to be displaced cranially upwards. Eventually, its entry point shifts to the urogenital sinus, completely independent of the original Wolffian duct it budded from.
That sounds like a complex migration.
It is. And this specific complex displacement mechanism is the embryological reason why we sometimes encounter aberrant ureters in gynecological surgery.
You mean like a ureter opening into the vagina?
Exactly. Or into the uterus instead of the bladder. If that developmental timeline, that migration is just slightly off, the ureter's normal path is disrupted.
Which makes it vulnerable later in life.
Highly vulnerable to accidental ligation or damage during complex pelvic surgeries like hysterectomy. Knowing this embryology helps the surgeon anticipate where a ureter might be if it's not where it's supposed to be. That's professional insight.
Okay, so we've established the shared origins, the intermediate cell mass, the kidney development intertwined with the Wolffian duct. But where does the specific female anatomy was the tubes, the uterus, branch off from that shared template?
Right, now we focus on the star players for the female tract, the ducts. These appear as two parallel ridges between the 5th and 8th weeks.
The mesonephric and paramesonephric duct.
Correct. Mesonephric is the Wolffian duct, which we've discussed. Paramesonephric is the Mullerian duct. And the critical differentiation here is genetic.
No Y chromosome means?
No Y chromosome means no significant production of two key substances, Mullerian inhibiting factor, or MIF, and no high levels of testosterone.
So without those male signals, the Wolffian duct, which is essential in the male,
it largely disappears in the female. It regresses, leaving only those small vestigial remnants we talked about, the apophoron, paraphoron, Gartner's duct.
And in the absence of that inhibition from MIF.
The Mullerian duct, the paramesonephric one, thrives. It develops into the core female genital organs, the fallopian tubes, the uterus, and the upper part of the vagina.
How does the Mullerian duct itself form?
It actually forms as an invagination, like a groove folding inwards of the coelomic mesothelium. That's the lining of the abdominal cavity. This invagination starts near the pronephros region superiorly, forms a funnel shape, and extends downwards towards the primitive cloaca.
And its position relative to the Wolffian duct is important.
Absolutely vital for professionals to visualize. The Mullerian duct lies ventral, that's in front of the Wolffian duct. They run parallel for a bit.
Why is that proximity so key?
Because their intimate anatomical closeness during early development explains why errors in the regression of the Wolffian duct can physically interfere with the Mullerian ducts. It can block their fusion or mess up their development, leading to combined anomalies.
Yeah, makes sense. So if we trace the Mullerian journey,
the lower caudal parts of the two Mullerian ducts swing towards the midline. They approach each other and eventually fuse together.
And the upper parts?
The upper parts remain separate, unfused. These develop into the fallopian tubes. This whole process, the fusion below, staying separate above, defines the internal anatomy we see every day in the clinic. Okay, let's get into the specifics of organogenesis. Those cranial, free parts of the Mullerian ducts, the bits that never fused, they remain as the fallopian tubes.
Fairly straightforward.
Mostly, yes. Though it's worth noting, small accessory ostia, like little extra openings near the main fimbrial end, aren't uncommon. Usually asymptomatic, but good to know they exist.
All right. And the real structural heavy lifting happens where the ducts did meet and fuse.
Exactly. That middle fused portion forms the uterus and the cervix. And the uterus itself becomes structurally identifiable quite early, actually, by the end of the 3rd month of intrauterine life.
That early? Wow. So problems detected later, like an infantile uterus.
They trace right back to failures in these very early growth and differentiation phases. It's a direct link. Embryology isn't just theory, it dictates clinical findings decades later.
How does the wall itself develop? The muscle?
The muscle wall, the myometrium, differentiates from the surrounding mesoblastic tissues, the mesoderm. We see the circular layer of muscle developing by the 5th month.
And the longitudinal layer.
That appears a bit later, during the 7th month. And interestingly, the source material notes that this longitudinal muscle layer is morphologically continuous with the plain muscle tissue of the ovarian ligament and the round ligament.
Ah, showing that unified origin from that mesodermal fold. Makes sense. They're all connected structures in surgery.
Precisely.
Now, what about the proportions? I remember reading the cervix is initially much bigger than the uterine body in the fetus.
That's right. In the fetus and the neonate, the cervix is significantly longer and thicker than the body, the corpus of the uterus.
That normally changes.
It normally flips around puberty due to estrogen stimulation causing the corpus to grow much more. However, if that infantile proportion persists into adulthood where the cervix remains disproportionately large compared to the corpus, that's when we clinically diagnose an infantile uterus. That's the uterus infantilis, which falls under the ESHRE-U1 classification we'll discuss later.
Interesting. And the glands develop at different times too?
They do. Cervical glands are recognizable much earlier, around the 6th month. But the glands of the uterine body, the endometrium proper, they develop significantly later, really only in the last month of intrauterine life. It highlights a differential maturity between these tissues.
Okay, so these structural facts, these timings, they really underscore the 3 crucial developmental steps. The ones that, if they fail, lead to the whole spectrum of anomalies we see.
Exactly. We can categorize pretty much all Müllerian developmental failures based on which of these 3 sequential steps went wrong. First, organogenesis. Did the ducts even form properly? Failure here leads to aplasia, like MRKH syndrome where the uterus is absent. Second, fusion. Did the lower segments join correctly in the midline? Failure here leads to duplication anomalies, like uterus didelphys or a bicornuate uterus.
And third.
Finally, septal resorption. After the ducts fuse, does the intervening wall between them disappear to create a single cavity? Failure here leads to a septate uterus.
So organogenesis, fusion, resorption. A professional needs to instantly identify which failure mode they're looking at to understand the anomaly and plan treatment.
That's the framework. Hashtag 2.2, development of the vagina and external genitalia.
Now, vagina development. This always seems notoriously complex, probably because it involves tissues from 2 different embryonic origins fusing, right? That's where the vertical defects come in.
It is a critical handover point, absolutely. So the lower ends of those fused Müllerian ducts form a solid structure called the Müllerian tubercle. This proliferates downwards, forming a solid vaginal cord.
Okay, a solid cord.
Which elongates caudally downwards until it meets bilateral structures called the synovaginal bulbs. Now, these bulbs are different. They're endodermal evaginations, little outgrowths, originating from the posterior wall of the urogenital sinus.
So Müllerian from above, urogenital sinus from below.
Exactly. They meet and fuse to form the vaginal plate. This plate is initially solid, but then it canalizes, develops a lumen, hollows out to create the vaginal canal.
Let's pause on that 2-source origin again, because that's the key to understanding those vertical defects, the transverse ones.
Think of it like this. The vagina is built in, sort of, 2 halves meeting. The modern, more nuanced view is that only the upper 1/3, or maybe even just the upper 1/5 of the vagina is actually derived directly from the Müllerian ducts.
And the rest.
The lower 2/3, or even 4/5, depending on the source, is derived from the urogenital sinus via that synovaginal plate mechanism.
So the junction point is the weak spot.
That interface, where these 2 different embryonic tissues meet and need to perfectly fuse and then canalize, that's the site where we often see failure. That's where a transverse vaginal septum typically forms.
Makes perfect sense embryologically. And the hymen itself, where does that fit in?
The hymen is simply the remnant of the embryonic septum that existed between those synovaginal bulbs and the main cavity of the urogenital sinus below.
So failure of that final thin membrane to break down.
That leads to the highly obstructive, imperforate hymen. It's purely a urogenital sinus origin issue, a failure of canalization at the very end.
Okay, got it. Moving outwards, ventrally, let's look at the external genitalia. These are clearly recognizable by the 12th week of IUL, right?
Correct. Development here starts with the division of the primitive cloaca. Remember that common chamber? It gets divided by the urorectal septum.
Right, separating urinary genitals from digestive.
Exactly. It separates the ventral part, the urogenital sinus, UGS, from the dorsal rectum. That septum eventually forms the perineal body between the vagina and anus.
And the urogenital sinus itself gives rise to.
The UGS is the origin for the bladder, the urethra, and the vestibule, the area surrounding the vaginal and urethral openings.
And the structures we see externally. Clitoris, labia.
The clitoris develops from the genital tubercle, which is a bilateral mesodermal structure appearing around the 5th week. The genital folds, which pass backward laterally to the urogenital sinus, fuse posteriorly and enlarge to form the labia majora. These are homologous to the male scrotum.
And the labia minora.
They form from the breakdown of the anterior part of the cloacal membrane, essentially the unfused parts of the urethral folds flanking the vestibule.
Okay, and the glands. Bartholin's, Skene's?
They're downgrowths, little buds, from the urogenital sinus epithelium. Bartholin's glands posteriorly and Skene's paraurethral glands anteriorly near the urethra.
And there's that great little conversational nugget or trivia piece. Skene's glands are homologous to the male prostate gland.
It is. A direct reminder of that shared ancestry, the common starting point before differentiation takes over. Hashtag tag 2.3 sexual determinants and homologs. We really need to hammer this foundational principle home. The default sexual development pattern for all embryos is unequivocally female. Meaning development proceeds along the female line unless it is actively and sufficiently influenced by specific male factors. Female is the baseline.
So male differentiation isn't automatic. It requires specific signals.
It's the active, energy-consuming process. It requires two key substances produced by the fetal testes, starting around the 10th week or so.
What are they?
First, Müllerian inhibiting factor, MIF. This is a powerful glycoprotein secreted by the Sertoli cells in the developing testes.
Yeah.
Its sole job is to actively inhibit and suppress the development of those Müllerian ducts. Stop them in their tracks.
Okay, so MIF gets rid of the female internal structures. What about promoting the male ones?
That's the job of testosterone, produced by the Leydig cells in the testes. Testosterone is responsible for nurturing and completing the development of the Wolffian duct structures, turning them into the vas deferens, seminal vesicles, epididymis.
And the external genitalia.
That requires another step. Testosterone needs to be converted locally to the more potent androgen, dihydrotestosterone, DHT, by the enzyme 5-alpha reductase. It's DHT that drives the development of the penis, scrotum, and prostate from those primitive external structures.
It really is a delicate hormonal cascade, isn't it? A lock-and-key system. If any part fails.
The outcome changes dramatically. A genetic male, 46XY, who has tests making MIF and testosterone, but whose cells cannot respond to the testosterone due to faulty receptors.
That's androgen insensitivity syndrome.
Exactly. They develop externally as female because the feminizing effect of testicular estrogen isn't opposed, and the masculinizing effect of androgen fails, even though MIF worked to suppress the Müllerian ducts. We'll get into that differentiation later. It's critical.
Conversely, abnormal hormone exposure in a developing female.
Right. A 46XX female fetus exposed to androgens can undergo varying degrees of masculinization. We call this female pseudohermaphroditism.
Where might those androgens come from?
Could be from the mother having certain ovarian or adrenal tumors like an areноblastoma that produce androgens, or historically from the mother taking certain progestogens during pregnancy that had mild androgenic properties. It shows how external factors can sometimes override that basic female blueprint.
To really solidify this shared origin concept, let's quickly review the homologous structures. It's the most effective way to see the links.
Okay, let's do a quick point-by-point using the table data.
Beferhose
Leads to the apophoron and porophoron remnants in the female, but forms the vas deferens and epididymis in the male.
Kermesiniferous duct. Müllerian.
Forms the fallopian tubes, uterus, upper vagina in the female, suppressed to just a vestigial appendix testis or hydated of Morgani in the male.
Genital tubercle.
Becomes the clitoris in the female, the penis in the male.
Genital folds.
Form the labia majora in the female, fuse to form the scrotum in the male.
Urogenital sinus.
Forms the lower vagina, vestibule, urethra, Bartholin's, and Skene's glands in the female. Forms the prostate, bulbourethral glands, and urethra in the male.
It's really elegant when you lay it out like that. Whether a structure regresses, persists, or differentiates hinges almost entirely on that Y chromosome dictating the hormonal environment.
Precisely. Presence or absence of MIF and effective testosterone action. That's the switch.
Okay, let's shift gears now and focus on the ovaries themselves. Unlike the ducts, where female is the default, ovarian development is an active genetic process, right?
That's a key distinction, yes. Ovarian differentiation requires two intact X chromosomes, XX, and a specific determinant located on the short arm of the X chromosome. It's an active genetic program starting early around the 5th week.
And the actual germ cells, the ones that become eggs, they don't start in the ovary, do they? They have quite a journey.
They have a tremendous migratory journey. The primordial germ cells actually originate way outside the gonad in the endodermal cells of the yolk sac around the 4th week.
The yolk sac. Wow.
Yep. And then they have to migrate along the dorsal mesentery, basically crawling along the gut tube to reach the genital ridge.
And their arrival is critical.
Absolutely critical. They act as organizers. When they arrive at the genital ridge, they induce the adjacent stromal cells, the coelomic epithelial cells, to differentiate into granulosa cells. These then surround the germ cells, forming the primordial follicles. No germ cells arrive. No proper ovary develops.
And the numbers involved are just staggering.
They really are. Those primordial follicles proliferate like mad, reaching a peak of maybe 6 to 7 million by the 7th fetal month. 7 million potential eggs.
But most don't make it.
Not even close. There's massive programmed cell death atresia that kicks in even before birth. By the time the baby is born, that number has plummeted to maybe 1 or 2 million follicles.
And the loss continues after birth.
Relentlessly. Throughout childhood and reproductive life, follicles are constantly undergoing atresia. Out of those initial millions, only about 300 to 400 will ever actually mature fully and ovulate in a woman's lifetime.
7 million down to maybe 400. It puts folliculogenesis in perspective. So many cellular hurdles to overcome just for normal function.
It really does.
Okay, what about ovarian descent? They don't start in the pelvis, do they?
No, they develop high up in the lumbar region, near where the kidneys develop. This reflects the origin of the ovarian blood vessels, which come directly off the abdominal aorta, high up.
And they migrate down.
They gradually descend during fetal life, usually reaching the pelvic brim by the time of birth. This descent is guided in part by a structure called the genital fold, or gubernaculum.
The gubernaculum, like in males.
Exactly, it's homologous. This fold connects the lower pole of the ovary to the region of the internal abdominal ring near the groin. As development proceeds, and particularly as the Müllerian duct crosses its path, this fold effectively gets split.
Split into what?
Into the proximal part, which becomes the ovarian ligament connecting the ovary to the uterus, and the distal part, which becomes the round ligament running from the uterus through the inguinal canal to the labia majora. Hashtag tag 3.2 anomalies of the gonads and undescended ovaries. So, if that genetic programming or the germ cell migration goes wrong, we see gonadal anomalies. Complete absence, aplasia, is very rare, but the more recognized form is the streak ovary.
Which we associate strongly with Turner syndrome, the 45XO karyotype.
So the streak ovary is the classic finding in Turner syndrome. It's characterized by the failure of those primordial germ cells to successfully migrate into the gonad, or perhaps they arrive but degenerate very quickly.
So what was left?
The resulting structure, the streak, contains undifferentiated ovarian stroma, the supporting tissue, but it's completely devoid of any germ cells or follicles. It cannot produce eggs or significant hormones.
Okay. What about the rare instances where ovaries just don't descend properly? They remain high up above the pelvic brim. Is that clinically important?
Undescended ovaries are rare, but yes, clinically significant. Their main importance lies in their frequent association with Müllerian duct anomalies.
Really? How strong is the link?
Quite strong. Undescended ovaries are found in conjunction with a completely absent Müllerian system uterine aplasia, U5, in up to 40% of cases. And with a unicornuate uterus, a hemiuterus, U4, in about 20% of cases.
So finding an undescended ovary is a major red flag.
It's an immediate red flag that there might be a significant underlying Müllerian tract issue. The failure of the ovary to descend often correlates with incomplete development of the ligaments and ducts, like the round ligament, that normally guide that descent.
And are there risks associated with the undescended ovary itself, similar to an undescended testes?
There are potential risks, yes. There's a theoretical increased risk of malignancy, although perhaps not as well defined as with testes. Clinically, their high location can make things difficult, like monitoring ovulation if trying to conceive. Or pain from the ovary, maybe from a cyst or torsion, could be easily misinterpreted as appendicitis or some other intra-abdominal issue because of the location.
So what's the usual management?
Often, surgical removal is suggested, especially if there's no functional uterus. This removes the diagnostic confusion and any potential tumor risk. If removal occurs before menopause, then hormonal replacement therapy, HRT, would be needed. If a functional uterus is present, well, then assisted reproductive techniques using eggs from that ovary might still be an option, though retrieval could be challenging. Hashtag tag 3.3 Wolffian duct anomalies and remnants.
Let's quickly revisit those Wolffian duct remnants we mentioned earlier. They don't always just sit there quietly, do they? They can form cysts. We talked about paraovarian and Gartner cysts.
Exactly. They can definitely cause clinical issues. If the upper portion of the Wolffian duct system, up near the tube and ovary, dilates, it forms a paraovarian cyst.
And differentiating that from an actual ovarian cyst is key.
Absolutely crucial for the surgeon. A paraovarian cyst lies outside the ovary, typically nestled within the leaves of the broad ligament. On ultrasound or at surgery, you can usually see the ovary separate and looking normal next to the cyst.
Any surgical pitfalls?
The main one is the ureter. The ureter runs through the base of the broad ligament, potentially quite close to a large paraovarian cyst. Careful dissection is needed to avoid injuring it during removal of the cyst.
Okay, so paraovarian cyst is high up
Yeah.
in the adnexa. What about Gartner's cyst? What's the clinical signature there? How do we spot it lower down?
Gartner's cyst comes from dilation of the lower persistent portion of the Wolffian duct, the actual Gartner's duct remnant. These typically occur along the pathway of that duct, which runs in the connective tissue alongside the uterus and then down into the vaginal wall.
Where in the vaginal wall specifically?
Most commonly, they're found in the anterolateral wall of the vagina. That location is key for differentiation. Most common vaginal inclusion cysts, from childbirth trauma for instance, tend to be posterior. Seeing a cyst anterolaterally should make you think Gartner's in management.
If it's small and asymptomatic, you just leave it alone. But if it becomes large enough to cause symptoms, particularly pain during intercourse, dyspareunia, then surgical management is needed. Usually marsupialization, opening it and sewing the edges open, or complete excision if possible. Again, knowing the embryology predicts the location. All right, now we dive into the core pathology. Mullerian duct anomalies, or MDAs. These result from some arrest or failure of that normal developmental sequence we've outlined. Before we tackle the modern ESHRE classification, maybe quickly touch on the older Jones classification that set the stage.
Yeah, Jones's system was foundational. It categorized failures based more on the overall outcome. Things like 1. Aplasia, complete failure to develop. Think MRKH, total uterine absence. 2. Hypoplasia, organs formed but are rudimentary, underdeveloped. 3. Atresia. This was about failure of canalization, leading to blockages, what we call gynatresia, like an imperforate hymen. 4. Mullerian duct anomalies. This was the broader category covering the fusion failures and the septal disappearance failures, things like unicornuate, bicornuate, septate uteri.
So useful, but maybe less precise than we need now.
Exactly. But regardless of the specific classification system, it's vital to remember that all these congenital defects boil down to a failure in one of those 3 critical mechanical steps we identified earlier.
Right. Vertical fusion, lateral fusion, or resorption.
Precisely. Let's recap those quickly because they explain the types of anomalies. 1. Vertical fusion failure. This is where the Mullerian ducts coming down fail to properly connect and canalize with the urogenital sinus derivatives coming up. This creates transverse blockages, like a transverse vaginal septum or an imperforate hymen.
Okay, vertical means blockage top to bottom.
Right. 2. Lateral fusion failure. This is where the 2 parallel Mullerian ducts fail to join together correctly in the midline. This results in duplication anomalies, 2 horns, maybe 2 cervices, like uterus didelphes or a bicornuate uterus.
Lateral means side by side didn't join.
Exactly. And 3. Resorption failure. Here, the ducts did fuse correctly, but the midline septum, the wall between them, failed to dissolve or resorb afterwards. This leaves a dividing wall inside a single uterus, the septate uterus.
Got it. Vertical, lateral, resorption failures. That framework helps visualize the different anomaly types.
Yeah.
#tag, #4.2 vertical fusion defects.
Obstructive
lesions. Okay, let's start with those vertical fusion failures, the obstructed lesions. These often create surgical emergencies right around puberty, don't they?
They absolutely do. The classic example is the imperforate hymen. As we said, this is purely a vertical defect. That final embryonic membrane at the vaginal opening just fails to break down.
And it goes unnoticed until menarche.
Almost universally, yes. The girl starts producing estrogen, develops secondary sexual characteristics, the uterus starts menstruating, but the blood has no way out.
So the classic presentation of puberty is what? Primary amenorrhea, she's never had a period.
Correct. Combined with severe cyclical lower abdominal pain. It comes and goes month after month, often getting worse.
And that pain is from the trapped blood.
Exactly. The retained menstrual blood builds up, first distending the vagina, that's hematocolpos. If it continues, it backs up into the uterus, hematometra, and even out into the fallopian tubes, hematosalpinx.
And this buildup can cause other symptoms.
Yes, the pressure from this mass of trapped blood can press on the bladder, causing urinary symptoms like difficulty voiding or even retention. And often you can feel a tender midline suprapubic lump on abdominal exam. That's the distended vagina and uterus.
Diagnosis is usually clinical.
Usually straightforward. On external genital examination, you see a characteristic bulging, often bluish membrane where the vaginal opening should be. That's the hematocolpos pushing the hymen outwards.
And treatment is surgical.
Simple, crucial incision, usually excising a segment of the hymen to create a lasting opening. But it needs care. Relieving that pressure suddenly can be dramatic, and there's a real risk of ascending infection once the blockage is opened. Strict aseptic technique and often antibiotic cover are really important.
Okay. What about the other vertical defect, the transverse vaginal septum? Much rarer, you said.
Much rarer, maybe 1 in 80,000 or so women. This is a septum within the vaginal canal itself. If it's complete imperforate, it causes the exact same obstructive symptoms as an imperforate hymen, primary amenorrhea, cyclic pain, hematocolposmetra.
And where do these typically occur?
The most common site, accounting for nearly half the cases, is at the junction of the upper and middle third of the vagina.
Which makes sense, as that's the likely meeting point.
Exactly, that critical interface point between the downgrowing Müllerian portion and the upgrowing urogenital sinus portion. A failure of fusion or canalization right there. Hashtag tag 4.3 lateral fusion defects, duplication.
Okay, moving on to the lateral fusion defects. This is where the two Müllerian ducts just didn't join up properly side by side, leading to duplication.
Right. The extent of the non-fusion determines the anomaly. These are often categorized based on symmetry.
Symmetrical defects being
Things like uterus didelphes, which is complete duplication, 2 separate uterine horns, 2 separate cervices, and often a double vagina as well. Then you have the bicornuate uterus variants, where there's partial fusion, resulting in 2 horns, but maybe only 1 cervix, or still 2. The arcuate uterus is the mildest form, just a slight indentation at the top, representing near complete fusion.
But it's the asymmetrical defects that often carry the highest immediate risk profile, isn't it?
Absolutely. Asymmetrical development is where one Müllerian duct develops normally, forming one uterine horn, a hemiuterus, but the other side fails to develop properly, leaving only a rudimentary horn.
And that rudimentary horn is the problem.
It can be a huge problem depending on its characteristics. It might be non-functional, just a fibrous nubbin, or it might have a cavity. If it has a cavity, it might communicate freely with the main uterine horn. That's lower risk.
But the dangerous one is.
The truly critical high-risk subset is the non-communicating functional rudimentary horn.
Okay, break that down. Why is that combination, non-communicating but functional, a ticking time bomb?
Right. Functional means it possesses active secretory endometrium. So it menstruates each month just like the main horn. But non-communicating means that menstrual blood has no outlet into the main uterus or vagina. It gets trapped.
Leading to
a massively distended, blood-filled structure called a hematocavity or hematometra within that rudimentary horn. Clinically, this presents with severe, often incapacitating, unilateral cyclic pelvic pain, frequently starting in adolescence, and often initially misdiagnosed as severe dysmenorrhea or endometriosis.
And there's another major risk, too.
Yes, and even more catastrophic risk. If sperm manage to travel up the main horn, across the fallopian tube on that side, and fertilize an egg released from the ipsilateral ovary, implantation can occur within that rudimentary horn. This results in an ectopic pregnancy in a structure completely incapable of supporting it.
Which inevitably leads to rupture.
Almost inevitably, yes. Rupture of a rudimentary horn pregnancy is a life-threatening surgical emergency due to massive internal hemorrhage. This is why diagnosing a non-communicating functional rudimentary horn mandates its urgent laparoscopic removal, ideally before a pregnancy occurs.
Wow. Okay, and again, whenever we find any Müllerian anomaly, especially these unilateral ones,
the professional mandate kicks in immediately. Think associated anomalies. Wolffian duct remnants and, more importantly, renal tract anomalies frequently coexist with MDAs. This is particularly true for unilateral Müllerian defects like the unicornuate uterus or a hemiuterus with a rudimentary horn.
So imaging the kidneys is essential.
It is absolutely mandatory. Detailed renal ultrasound, or sometimes an older test like an intravenous pyelogram IVP, must be performed in all diagnosed cases of MDA. You have to look for things like renal agenesis, a missing kidney, a malrotated kidney, an ectopic kidney, pelvic kidney, or horseshoe kidney. These renal issues usually found on the same side as the Müllerian abnormality. Failing to check the kidneys is a major oversight.
Okay, so we've seen the types of failures. To really communicate effectively about these complex conditions in a modern professional setting, we need a standardized system. That brings us to the 2013 ESRI classification.
Right. This system aimed to be clearer and more clinically relevant than older ones. It's based purely on anatomy, specifically the uterine morphology. It uses the embryological origin for the main classes, numbered U0 to U5, and then subclasses denote different degrees or types of deformity within each class.
U0 being normal.
U0 is normal, so the anomalies start with U1. This classification requires us, as professionals, to move beyond just saying bicornuate or septate. We need to apply rigorous measurement standards, often using 3D ultrasound or MRI.
Okay, let's define these key classes that elite professionals use. What's class U1, dysmorphic uterus?
U1 is defined by a normal external uterine outline, so the top of the fundus looks smooth, but the internal cavity shape is abnormal, excluding the presence of a septum.
So weird cavity shape, normal outside.
Essentially, yes. The two important subtypes are U1A, T-shaped uterus. Here, the cavity is narrow and shaped like a T, usually because the lateral walls are abnormally thickened. This is classically associated with in utero exposure to diethylstilbestrol, DES, though it can occur without it, and U1B, uterus infantilis. This also has a narrow cavity, but without that lateral wall thickening. Its defining feature is that inverse corporeal cervical ratio we talked about earlier. The cervix is much longer than the uterine body, like 13 body, 23 cervix.
Okay. Next, class U2, septate uterus. You said this is the resorption defect and the most common anomaly overall.
By far the most common, yes. U2 is defined again by a normal external fundal outline. This is the absolute key measurement for distinguishing it from U3.
How normal is normal?
The rule is, any external indentation at the fundal midline must be less than 50% of the uterine wall thickness. So it looks smooth or only slightly dipped on the outside.
But the pathology is internal.
Exactly. The pathology is the failure of that midline septum to resorb after fusion. This results in an internal indentation, the septum itself, which must exceed 50% of the uterine wall thickness to qualify as U2. It can be partial or complete, extending down to the cervix.
No. Okay, wait. So the critical difference between U2, septate, the most common one, and the next category, U3, bicorneo-bicorporeal, often hinges entirely on one measurement, whether that external dimple at the fundus is shallow or deep relative to the wall thickness.
That is the absolute crux of the E3 classification for these two. That external contour measurement is the defining professional nuance. It tells you immediately if the problem was failed resorption, U2 smooth outside, or failed fusion, U3 indented outside.
Because if the septum just failed to resorb, the outside shape should have formed normally.
Precisely. But if the two ducts failed to join correctly in the first place,
the external shape must reflect that failure. Which brings us to class U3, bicorporeal uterus, the lateral fusion defect. How does the 50% rule apply here?
For U3, it's the opposite. U3 is defined by an abnormal fundal outline. Specifically, there must be an external indentation at the fundal midline that exceeds 50% of the uterine wall thickness. That deep external cleft is the structural evidence of the underlying lateral fusion failure.
And the subtypes.
U3 includes partial bicorporeal, U3A, indentation doesn't reach the cervix, complete bicorporeal, U3B, deep cleft, usually two cervices, essentially uterus didelphes, and septate bicorporeal, U3C, which is rare.
Okay, clear difference based on that external contour. What's next? Class U4, hemiuterus.
U4 is defined by essentially unilateral Müllerian development. Only one side formed properly. You have a single uterine horn. The key distinction within U4 is about the other side.
The rudimentary horn.
Exactly. U4A is a hemiuterus with a rudimentary horn that has a functional cavity. This is that high-risk one we discuss, risk of pain, hematocavity, ectopic pregnancy. U4B is a hemiuterus where the rudimentary horn is non-functional, either absent or just a solid cord without a cavity. Much lower risk.
Got it. And finally, class U5, aplastic uterus.
U5 is complete Müllerian aplasia. The defining feature is the absence of any developed uterine cavity. This includes cases with bilateral rudimentary horns or just complete absence. The classic example is MRKH syndrome, #tag 5.2, adverse obstetric outcomes and diagnosis.
Now, why is getting this classification right so critical? It directly impacts prognosis, especially reproductive outcomes, right?
Hugely. The different classes carry very different risk profiles. Let's take the septate uterus, U2 again. It's strongly associated with reproductive loss, particularly spontaneous first trimester abortions rates. Around 25% are often quoted, and also second trimester losses, around 6%. Also preterm labor.
And the mechanism for that loss for counseling patients, why is that septum so bad for pregnancy?
The leading theory, supported by histological studies, is poor vascularization. The septum itself is mostly fibrous tissue, not rich, receptive endometrium like the normal uterine walls. When an embryo implants onto this poorly vascularized septum, it just can't establish a good enough blood supply, leading to implantation failure or early miscarriage.
Which is why surgically removing the septum often improves outcomes so dramatically.
Exactly. Hysteroscopic resection creates a more normal cavity lined by healthier tissue.
Now contrast that with the fusion defects. What about the bicornuate uterus, U3? Does it cause early miscarriages?
Generally, no. U3, the bicornuate uterus, is not typically associated with recurrent first trimester losses like the septate uterus is. The issue with U3 is more about the reduced size and potentially abnormal shape of each horn.
Leading to problems later in pregnancy.
Yes. Increased rates of preterm birth, fetal malpresentation like breech or transverse lie because the baby doesn't have the normal ovoid space to position itself, and sometimes IUGR, C-section rates are higher.
And the hemiuterus, U4. That sounds like the worst prognosis overall.
In terms of carrying a pregnancy to term successfully, yes, U4 often has the most severe obstetric outcomes. Spontaneous abortion rates are high. If pregnancy continues, the incidence of prematurity is very high, IUGR is common, and malpresentation is almost the rule.
What are the survival rates like?
Older data suggested live birth fetal survival rates in women with untreated unicornuate uteri might be only around 40–50%. Very challenging pregnancies, often requiring intensive monitoring and management.
Okay, so given that the treatment differs radically, U-septate usually gets hysteroscopic resection, while U3 bicornuate might need complex laparoscopic reconstruction, metroplasty. If anything, accurate diagnosis is absolutely paramount.
Paramount. This is the definitive diagnostic challenge where expertise really shines.
What are the best tools?
3D ultrasound has become incredibly powerful. In expert hands, it's highly sensitive and specific for differentiating U2 from U3 by clearly visualizing both the internal cavity and that crucial external fundal contour. MRI is also excellent, perhaps the best for providing precise anatomical detail of all pelvic viscera, again, clearly showing the external shape.
So 3D US or MRI are first line.
Generally, yes. However, sometimes there's still ambiguity or surgery is planned anyway. In those cases, the traditional gold standard for definitively separating U2 and U3 might still involve a combined approach. Hysteroscopy, looking inside the cavity to see the septum, performed concurrently with laparoscopy, looking at the outside of the uterus to assess the fundal contour.
Right, the ultimate visual check. See a normal, smooth exterior, but an internal dividing wall. It's a septum, U2. See a deep cleft or indentation on the outside. It's a fusion defect, U3.
That's the logic exactly. Just a quick note on older imaging. Hysterosalpingography, HSG, the dye test, is much less reliable for this specific distinction. While experienced radiologists might look for the angle of divergence between the horns, typically less than 75 degrees suggests a septate uterus, HSG simply cannot definitively assess the external contour. It only shows the inside. That's why 3D US or MRI are vastly preferred now. Okay, let's zoom in on class U5, Mullerian agenesis. The most well-known form is Mayer-Rokitansky-Kuster-Hauser syndrome, usually just called MRKH syndrome.
So the defining features here are the absence of the uterus, the cervix, and the upper part of the vagina. But critically, what is present and normal?
Critically, these individuals have normal ovaries that function, producing estrogen and causing normal puberty, and they have a normal female karyotype, 46XX.
So they present how?
Typically, they present in their early teens with primary amenorrhea. They've hit puberty, developed breasts, pubic hair. Everything looks normal externally, but they've just never started menstruating because there's no uterus or endometrium to shed.
And their external phenotype is completely normal female.
Completely normal female external appearance, normal secondary sexual characteristics. They are, for all intents and purposes, normal females whose internal reproductive plumbing and the Mullerian-derived structures simply failed to form during embryogenesis, organogenesis failure.
Okay, and because of that shared embryological origin story we keep coming back to, what is the absolute mandatory next diagnostic step once MRKH is suspected or diagnosed?
Investigate the urinary tract. Immediately and thoroughly. A significant percentage, maybe up to 40%, of individuals with MRKH have associated urologic abnormalities.
Like what?
Things like renal agenesis, missing a kidney, pelvic kidney, ectopic location, horseshoe kidney, duplication of ureters, malrotation. And it doesn't stop there. About 20% to 30% also have associated skeletal abnormalities, particularly involving the spine.
So confirming MRKH isn't the end of the workup?
Not at all. A full renal ultrasound or IVP and sometimes spinal imaging is non-negotiable. You have to screen for these associated conditions.
Now, MRKH needs to be carefully differentiated from its main clinical mimic, right? Androgen insensitivity syndrome, AIS, because the management is drastically different. especially regarding the gonads.
This differentiation is absolutely critical for the clinician. Androgen insensitivity syndrome, AIS, formerly called testicular feminization syndrome, is fundamentally different. It's caused by a genetically transmitted defect in the androgen receptors. And crucially, the individual's karyotype is 46XY. They are genetically male.
But they look female externally.
Yes, because although their internal tests located intra-abdominally or in the inguinal region are producing MIF, so the Müllerian ducts regress, and testosterone, their body cells cannot respond to the testosterone due to the faulty receptors.
So what internal structures do they have?
They typically have no uterus or fallopian tubes because MIF worked. They also have no male internal structures like vasa deferens because testosterone action failed. They have internal tests, which are abnormal gonads prone to malignancy later in life, necessitating their removal, usually timed after puberty is complete, to allow for spontaneous breast development from testicular estrogen. The vagina is usually absent or very short and blind ending.
Okay, 46XY, testes present, no uterus. MRKH is 46XX, ovaries present, no uterus. But externally, they can look similar. What's the key clinical feature that often helps differentiate them externally before karyotyping?
The crucial clinical differentiator, the one professionals look for, is often body hair. Because the androgen receptors are defective in AIs, even though the testes are producing high levels of testosterone, the body cannot respond to it for things like hair growth in androgen-sensitive areas, pubic, axillary. Therefore, individuals with complete AI, CAIs, typically present with scanty or absent pubic and axillary hair.
Whereas MRKH patients,
being 46XX with normal ovaries producing normal female hormones and having normal androgen sensitivity from adrenal ovaries, have completely normal female patterns of pubic and axillary hair development. So hair pattern is a big clue. Of course, definitive diagnosis relies on karyotype, pelvic ultrasound MRI to confirm absence of uterus and presence of ovaries, MRKH, or testes, AIS, and checking hormone levels. Testosterone will be in the normal or high male range in AIS.
Hashtag 6.2 treatment strategy.
Yeah, let's talk treatment. For the septate uterus, U2, given its strong link to recurrent pregnancy loss, what's the standard approach?
For a symptomatic septate uterus, especially in the context of recurrent miscarriage or infertility, hysteroscopic resection, sometimes called metroplasty, is considered the modern gold standard treatment. Why hysteroscopic?
Because you can resect the septum from within the uterus using an endoscope passed through the cervix. It's minimally invasive. The huge advantage is that it avoids making an incision in the uterine wall itself, meaning no uterine scar.
And why is avoiding a uterine scar so important?
Because a scar on the uterus, like from an older open metroplasty or even some laparoscopic ones, significantly increases the risk of uterine rupture during a future pregnancy or labor. Avoiding that scar means the patient usually doesn't require an automatic elective cesarean section for future deliveries. Hysteroscopic resection preserves uterine integrity.
Is it always indicated?
Generally indicated if the septum is causing problems like recurrent loss, and often considered if the septum is significantly long, say extending more than maybe 1 to 1.5 centimeters down or beyond 30% of the cavity length, although criteria vary.
And the postoperative care after hysteroscopic resection requires real attention to detail, doesn't it, to prevent complications like adhesions?
Meticulous post-op care is absolutely mandatory for success. Two main goals: promote healing, and prevent the raw surfaces from sticking together.
How do you achieve that?
First, hormonal support. Oral estrogen, often conjugated equine estrogen or estradiol, is typically given for 1 to 3 months afterwards. This helps the endometrium to regrow quickly over the raw area where the septum was cut.
And preventing adhesions, Asherman syndrome.
Right. To prevent the uterine walls from scarring together, Asherman syndrome, some form of physical separation is often used temporarily. A common method is inserting a pediatric Foley catheter with a small balloon, maybe 48 milliliter inflation, into the newly shaped uterine cavity and leaving it in place for about 5 to 7 days. An intrauterine device, IUD, or a specialized adhesion barrier gel might also be used. This is often combined with a short course of antibiotics to prevent infection and maybe NSAIDs for discomfort.
Okay, careful surgery, careful follow-up. Now, shifting gears to the management of vaginal agenesis and MRKH, the goal is to create a functional vagina, but timing is key.
Timing is absolutely key. Treatment to create a neovagina should always be delayed until the patient is psychologically mature, well-counseled, and importantly, motivated and ready to start sexual activity or use dilation regularly. Compliance is essential for success, especially with non-surgical methods. Forcing it too early often leads to failure.
And the non-surgical approach is preferred first.
Highly favored as the first-line approach, yes. This is Frank's method, or variations of it. It involves using graduated dilators, smooth, firm cylinders of increasing size.
How does it work?
The patient applies firm, constant pressure with the dilator against the perineum, directed towards where the vagina should be, typically for about 20 minutes, maybe 2 or 3 times a day. Over time, this pressure gradually stretches the existing vaginal dimple and creates a functional vaginal canal through tissue expansion.
And success rates?
Remarkably high when done diligently. Success rates over 75%, sometimes up to 90%, are reported, achieving a vaginal length adequate for comfortable sexual function. There are modifications, like Ingram's method using a bicycle seat stool with a dilator attached, which provides more constant perineal pressure without requiring the patient to use their hands for long periods.
So patience and persistence pay off. But if dilation fails, or if the patient strongly prefers a surgical route,
then surgical vaginoplasty becomes the option. There are several established techniques. The classic McIndoe operation involves surgically creating a space between the bladder anteriorly and the rectum posteriorly. Then, a mold or stent covered with a split-thickness skin graft, usually taken from the buttock, is placed into this space and left for several months while the graft takes. Requires long-term dilation afterwards, too. Other options include using grafts from fresh amniotic membrane instead of skin, or the Williams procedure, which uses flaps of skin from the labia majora to create a pouch, though the axis is less anatomical. There's also tissue expansion vaginoplasty, where a balloon expander is placed surgically and gradually inflated over weeks to create the space before grafting. Choice depends on surgeon experience and patient factors. Hashtag 6.3 malformations of the rectum and anal canal.
Okay, to really complete this picture of urogenital development and its anomalies, we should briefly touch on defects in the posterior division of that primitive cloaca, the part that forms the rectum and anus. These can sometimes present to gynecologists too.
Absolutely. The most severe is imperforate anus. This results from the complete failure of that cloac membrane to break down between the hindgut and the anal pit externally.
And this is usually obvious at birth.
Yes, it's typically diagnosed during the newborn examination when the nurse or doctor finds no anal opening or can't pass a thermometer. This requires immediate pediatric surgical consultation and correction.
But what about less obvious defects, like fistulas connecting the rectum and vagina?
Right, that's the rectovaginal fistula, or sometimes an ectopic anus. These result from an imperfect separation of the rectum from the urogenital sinus by that urorectal septum we mentioned earlier.
So the anus opens in the wrong place.
Exactly. Instead of opening onto the perineum, the anus might open directly onto the posterior vaginal wall, often just inside the hymenal ring or fourchette. This is sometimes called a vaginal anus or anteriorly displaced anus.
Can women function with that? Bowel control?
Surprisingly, yes. Many women with an ectopic anus manage to acquire reasonably satisfactory bowel control, although they may be prone to perineal irritation or infections.
But the key clinical risk for the gynecologist comes during childbirth.
Precisely. That ectopic opening on the posterior vaginal wall makes the perineal body extremely deficient and vulnerable. During vaginal delivery, attempting to push a baby past that point poses an exceptionally high risk of a severe, complex 3rd-degree or even 4th-degree perineal tear, potentially involving the misplaced sphincter mechanism.
So vaginal delivery is contraindicated.
It is almost universally recommended that women with a known ectopic anus deliver via cesarean section. Even if surgical correction of the anus was performed in childhood, the sphincter function might not be perfect, and C-section is generally considered the safer route to avoid devastating perineal trauma. #outro.
Wow. Okay, this deep dive has really traced the incredibly delicate, sequential journey of female reproductive development. It hammers home that it's all about shared origins, precise timing, and those critical failure points.
We moved from that primitive intermediate cell mass through the complex ductal fusion and resorption right up to the nuanced ESHRE classification system. And those 3 major failure types kept reappearing. Organogenesis failure, lateral fusion failure, and septal resorption failure. They really define the spectrum.
And the absolute core takeaway, the professional mandate that distinguishes the elite, is that established interconnectedness of the urogenital systems. You simply cannot separate them clinically.
That's it. Knowing the specific Müllerian anomaly type, using that ESHRE language, U1 through U5, has to immediately trigger the next step. Comprehensive screening for renal anomalies, ultrasound, maybe IVP in every single case. That systematic linkage of embryology to diagnostic protocol, that's the highest level of practice. That's mastery.
We've also firmly established that female development is the powerful default pathway. It only gets diverted if actively interrupted by those specific testicular hormones, MIF and testosterone.
Which brings us to a final provocative thought, something for you, the listener, to perhaps mull over. Well, considering how precise those hormonal controls need to be for male development to occur properly, and thinking about the, ever-increasing exposure to endocrine-disrupting chemicals in our modern environment, what future clinical scenarios might arise?
You mean from environmental factors?
Yeah. Could exposure to chemicals that perhaps weakly mimic MIF or block testosterone action during critical windows of fetal development be causing subtle, maybe subclinical errors in duct development? Things like very mild U1 dysmorphic uteri or slight T-shaping that we simply aren't currently screening for in the general population?
And these might only manifest later.
Exactly. Maybe only manifesting years down the line as unexplained infertility or subtle pregnancy complications that we can't quite put our finger on because the anomaly is below our current diagnostic radar. Are there potentially widespread low-level developmental disruptions happening that we haven't even begun to look for systematically?
That's definitely something to think about. A potential hidden layer of complexity driven by environmental interactions with this delicate embryology. Thanks for that final thought and for guiding us through this incredibly detailed deep dive.
My pleasure. It's a fascinating and vital area to understand thoroughly.